Hello and Assalamu alaikum again. So this is the second chapter of basics of dermoscopy. Initially, we started doing dermoscopy, and this was the first lecture that I recorded lastly, and we had already studied till chaos. We defined chaos and non-chaos. And if you remember from the last lecture, let's do it again. A bit of revision. Well, chaos is something where you see no symmetry. For example, in the lesion on the left-hand side, you see a darker spot on one side only and not throughout the periphery of the lesion. While on the right-hand side, you see that the color stays the same throughout the lesion, no matter what's the outline. So you don't really have to consider the outline of the lesion. You just have to see the arrangement of the structures within that lesion. If the structures are arranged symmetrically or non-symmetrically, and also concentrate on the color of the lesion. So for example, in this lesion, which seems pretty much beautiful and a very regular oval shaped lesion with a regular outline, but see the darker part is present in only one side. And as compared to the other lesion, which is on the right hand side, there is homogeneous pigmentation. There is no difference in the color of the lesion anywhere. And however, the outline is very much irregular. So you just don't consider the outline and label the lesion, the left side lesion, as a chaotic lesion. So that's the chaos. Well, this was the last slide where we stopped in the last lecture, and this is a slide beautifully depicting the chaos. For example, there are so many things to see in this slide. For example, these are the polygons, and similarly over here on the in the darker area, if you follow the cursor, these are different shapes, maybe closed shapes or partially open, and they've been lined by different lines having angles 90 degree or more. And these enclose partial or complete shapes of different sizes called the polygons. And polygons are characteristic feature for melanoma. On the right hand side, you see these streaks, peripheral streaks, and also a network kind of thing, but the network is very much atypical. It's not typical, pretty much visible in the right upper corner as well. And then there is a structureless area in the bottom half of the lesion. Also, there are few rounded, hyperpigmented, clots or dots, you may call them. On the left-hand side is a grayish area or peppering, okay? So there are so many things in one lesion, and these are distributed asymmetrically. So this is a chaotic lesion. By the way, this is yes, it's a melanoma. Okay, so now there is another basic principle that is very much important in your interpretation of the dermoscopic images. What's a pattern and what is a clue? So pattern is something, is a structure that you see in more than 20% of that field which you are seeing with the dermoscope or the field of the dermoscope. So more than 20%, if you see something, it's a pattern. And if less than 20% is a clue. Yes, pattern and clue. So pattern is more than 20% and clue is less than 20%. Okay. So as for example, in the left-hand side, you see that the pigment network is present in more than 20% of the lesional, of the surface area that you are seeing with the dermoscope. And we call it a pattern. So there's a pattern of pigment network. However, on the right-hand side, if you see this clod, is it a pattern or a clue? It's a clue. Why? Because it's present in only small part of the area and it's less than 20%. And if you see on these the serpentine vessels or the branched vessels, they make up more than 20% area. So you may see that the pattern of branched vessels is there, and the clue is that of a blue clod. What is this? Yes, this is a BCC. It's a slide of the BCC. And what's there on the left-hand side? The network is regular over here on the periphery, but in the central part, it's very much darker. The spaces that the network is enclosing do vary in their sizes. You see a structureless area in the middle, as well as some grayish area, grayish blue, peppering or dots. See, so the lesion is asymmetrical as well. So on the left-hand side is a melanoma and on the right-hand side is a BCC. Okay. So how do I teach dermoscopy? There are so many methods by which we teach dermoscopy. And this is one of the area of concern that for somebody, for some novice who doesn't know ABC of dermoscopy, which method are we going to prefer in order to make you better understand the dermoscopic, nomenclature, terms, and then features, and make you able to diagnose properly what is there in the dermoscopic images. There are so many methods. However, the two important categorizations of all the methods stays analytical approach and heuristic approach. In the analytical approach, as the name suggests, you're going to analyze various structures and patterns and different things, whatever you see in the dermoscopic image, and then you may use your brain to categorize that very image into either benign or pre-malignant or malignant or whatsoever the diagnosis may be. And you follow certain algorithms and roadmaps that are told to you, and you follow a different path. You just don't follow your basic instinct or your reflexes. You go through a proper roadmap, a proper set of instructions, and stepwise manner you go towards the diagnosis. However, there is another approach which is called the heuristic approach. What do you see? What do you, do in the heuristic approach? In the heuristic approach, whenever you see an image, your brain instantly tells you what kind of image that may be. As for example, you guys pretty much know how the face of your brother or your sister looks like. And if a face similar to yours or your brothers or sisters is seen in your life, you instantly say this face resembles my sister's face or this face resembles my brother's face. Why? Because your brain hasn't analyzed the face, but somehow, since you've been looking at that very face throughout your childhood, so you know that this face resembles my brothers or sisters. This is the heuristic approach. You see something and you know that it's kind of that thing. And it is only possible when your brain has been tuned up to so many images, so that your brain has already learned to name those images. And whenever similar lesions or similar images come up later in life, you can instantly point out, yes, I saw such kind of image, it was a melanoma, so this might be a melanoma. So that is a heuristic approach, that you're told that this type of image is malignant or chaotic or melanoma. And then later in life, when you come across such picture, you instantly say, okay, fine, this seems like melanoma. Why? You may not be able to tell why it seems like a melanoma, but you instantly follow your instinct or your sense of recognizing that lesion without really going into the details of roadmaps and instructions, etc., etc. And you memorize the lesions as such. This is also called the Gestalt appearance. So the methods of interpretations are so many. If you ask me what method of interpretation in dermoscopy do I prefer, so there are the last three. I have colored them red. I have made them prominent because these three methods are worldwide used. Most of them, because initially this is the evolution of dermoscopy, that initially classical pattern analysis was there in 1987, and then going forward, ABC method of dermoscopy was invented in 1994, and then Menzies method, which was concentrated on the positive features and the negative features. Then 7-point checklist also, only for the diagnosis of melanoma. 3-point checklist also for the diagnosis of melanoma. Then chaos and clues, basically, it's a composite method. I consider it superior to all the rest of the methods in terms of diagnosing differentiating benign from malignant or pre-malignant disorders. So chaos and clues is a method that you only use when you have to differentiate the benign lesions from the malignant ones. Then 1-point checklist or the elephant approach is the one which you use when you have to instantly say that the lesion is concerning or not. This is also called the elephant approach. We'll touch it shortly. And then the third method, which is famous worldwide, is the revised pattern analysis, which is an analytical method, and you follow the basic steps or the guidelines or the roadmaps to reach a final diagnosis. And the revised pattern analysis is basically used in the diagnosis of pigmented skin lesions. And then in a stepwise pattern, you get to know whether the lesion in question, the pigmented lesion in question, is a benign or a malignant one. Is it a concerning one or a non-concerning one? Usually in all the methods of dermoscopy, you don't come up with a proper diagnosis in the end. In all these methods, you come up with either the lesion is concerning or non-concerning. If the lesion seems concerning, you send the patient for biopsy. And if it is non-concerning, maybe you'll ask the patient to see you after 6 months or more. So all these last three methods are very much famous. They are pretty much used in everyday practice. And I'm sure you guys are also going to use them in your practice. Chaos and clues method, 1-point checklist, and the revised pattern analysis. Whichever method you use, the lucky part is that almost same diagnostic accuracy is being offered by all of them. So it doesn't matter whether you use the rapid pattern analysis or the Menzies method or the elephant approach. When they studied finally their diagnosing ability, almost all had the same diagnostic accuracy. So let's touch them one by one. First of all, we'll see the analytical method of interpretation of dermoscopic images, which is named a revised pattern analysis. If I just put my video on the right side. Okay. So this is a revised pattern analysis. And in this, it goes stepwise. So the first step is you see the patterns and the colors in the image you are seeing. Okay. Patterns and the colors. As I just told you, what is a pattern? A pattern is the repetition of the same structure, and it is there in more than 20% of the surface area of the lesion you're seeing, okay? So the pattern is the repetition of the basic structure. And what was the basic structure? The basic structures that we revised with the help of our hands, our fingers, there were 5 basic structures. Okay, let's revise them, okay? The 5 basic structures were line, pseudopod, circle, dot, and clod. Okay, so these were the 5 basic structures. If any of such structures is repeated over more than 20% of the area, it constitutes a pattern. And if it's less than 20% area, it constitutes a clue. So you see the patterns and the colors. If you see only one pattern in the lesion, you go for the colors. For example, if you see a lesion which is only network is there in the lesion, what color the network is of, then you see the colors. If the lesion is having only one pattern and the color is also only one, you say that the lesion is symmetrical. Kahani khatam. Okay. अब आपने आगे नहीं जाना. So you say that the pattern is one and the color is one, so the lesion is symmetrical. Just forget about it. Okay. Another option is there. If pattern is one, but it is of different colors, there are more colors, then either it could be symmetrical or it could be non-symmetrical. How you decide? Just simply on the basis of the 2 lines that are drawn through the middle of the lesion, one horizontal, one vertical, and then you see both sides, compare them. If they seem all right, the mirror image like or similar, you say that the lesion is symmetrical. And if they do not seem similar, then you say that the lesion is non-symmetrical. For example, if one side is more brown, the other side is more blue, you don't say the lesion is symmetrical, you say that it is asymmetrical. Okay, so you saw the patterns and then you saw the colors. So if there is one color, one pattern, lesion is symmetrical. And if there are more colors, the lesion could be either symmetrical or non-symmetrical. Okay, if you see more patterns, then what? If you see more patterns, then you only consider the structures and their arrangements. You just do not go for the colors. This is very, very, very important. Since the method is analytical one, so memorize it. You just have to go the way I'm telling you. There is no other way. You cannot go reverse. You see the pattern, you see the colors. If there is one pattern, you go for looking at the colors. But if there are more patterns, for example, you see the network as well, you see the dots or you see peripheral streaks, then instantly you go for looking at their arrangement. How are they arranged? Are they arranged symmetrically or non-symmetrically? You just do not consider their color. So the color is disregarded then. Okay. So step one, now just go stepwise and look at some examples. For example, the first is patterns and the colors. Okay, what pattern it is? You have to make up your mind. I'm giving you some time. What pattern it is? Is it one pattern or two patterns? Can I make it bigger for you? Let me see. Okay, if you were not able to make out, let's make it bigger for you. Hope this is bigger. Okay. So now that I have made it bigger for you, it's easier now to see that the top part is having some network. Middle part is structureless. At the bottom is a dark brown to black blotch. There is a network over here as well. And then there are few areas of homogeneous pigmentation. And the network is also more than 20%, blotch is also more than 20%, and homogeneous pigmentation is also more than 20%. Well, the structureless pigmentation or the structureless area, sorry, the structureless area is less than 20%. It would be a clue. So looking at whole of this lesion, the patterns are many. There are 2 to 3 patterns. So if you see many patterns, then what? Then the color is disregarded. You just see their arrangements. Now see the arrangements of the structures. नेटवर्क जो है वो सिमेट्रिकल है या नॉन सिमेट्रिकल है, ब्लॉच सिमेट्रिकल है या नॉन सिमेट्रिकल है, homogeneous pigmentation is symmetrical. Nothing is symmetrical, by the way. You draw a vertical line and you draw a horizontal line, you see that the halves of the picture are not identical, so you don't call it a symmetrical lesion, so you call it asymmetrical. Okay, इसको वापस अपनी हम जगह पे ले आते हैं छोटा करके. So हमने थोड़ी सी drill कर ली कि this was a lesion having multiple patterns, having 2 to 3 patterns. So we did not look at the colors, we saw their arrangements, and it was not symmetrical, it was an asymmetrical lesion. Now look at the second image. Okay, I think it's pretty much obvious. I don't have to really enlarge it. Okay, so if you see at this image, there are, is there one pattern or two patterns? I think the pattern more or less is only one. The pattern is of clods. The pattern is of clods. The clods are smaller, dense objects, and they are of single color. They are of multiple shapes. If they fit in together, they constitute a cobblestone pattern, but over here, they are not fitted tightly together. They are scattered here and there. So they constitute the clods. So there are clods. Some of them are smaller, some of them are bigger, but their distribution is symmetrical. Now, when there is one pattern, now go for the colors. So if the one pattern is giving you only one color, the lesion is obviously symmetrical. Is it one color? A little bit of anatomical variation is somehow tolerable. Well, the color is not gray or blue that you might be concerned. It's brown, a little lighter brown in the background, a bit darker brown in the clods. Well, the lesion is, to me, it's a symmetrical lesion. The pattern is one and the color is almost one. So I will call it the lesion is benign. However, if there is a recent history of change or patient has got some symptoms, maybe I would like to see this lesion after 3 months. And if the patient is very much concerned, I can also go for biopsy. So this is how you interpret the images. Okay. So जो लीजन पहला हमने देखा था उसमें देन भी सिमेट्री के ऊपर हम गए. पहले हमने पैटर्न्स देखे, फिर हमने सिमेट्री देखी. बाय द वे मैंने ये दोनों स्टेप्स आपको इकट्ठे करा दिए उन लीजन्स के ऊपर. Okay, so किस तरह के lesions आपको आने चाहिए? Initially, since we are concentrating on the basics of dermoscopy, these are the lesions that you should know when you start off with learning dermoscopy. Benign lesions में melanocytic nevus, seborrheic keratosis, solar lentigo, atypical nevus, and dermatofibroma is the minimum that you should know. And then in the malignant lesions, obviously the three cancers, BCC, SCC, and the melanoma. So these things are minimum necessary things for you to know in the basics of dermoscopy. So melanocytic nevi is the ABC of dermoscopy. जैसे हम dermatology की ट्रेनिंग शुरू करते हैं तो हमें सबसे पहले वो मैक्यूल, पैप्यूल और सारा कुछ ये सीखना पड़ता है. इस तरह dermoscopy में जो पहली चीज, पहला मॉड्यूल किसी भी ट्रेनिंग सेशन में होता है, usually this is on melanocytic nevi. Why? Because there is a chance of malignancy in the melanocytic nevi, and secondly, they are pretty much common to see in the general population. And since they can get malignant, a little bit of percentage is there throughout the lifetime. So we need to see them like very carefully in order to make up the diagnosis. Melanocytic nevi, as you can classify into two major groups, the congenital ones and then the acquired ones. Congenital ones are that further categorized depending upon their size into large, intermediate, and small, and the acquired ones are classified based mainly on the histology into junctional, spets nevus, blue nevus, and others. Junctional, compound, and dermal, depending upon the location, and then obviously histologically also into spets, blue, or other nevi. Risk of melanoma in congenital nevi is in small and medium, it's almost 0 to 4.9%, but in giant nevi, it's almost 16% lifetime risk. 5 to 15% is the lifetime risk. So we really have to see them in detail. Okay, so this is the morphological classification of melanocytic nevi, be it acquired or congenital. As you can see, the morphology means that the arrangement of the structures, the 5 basic structures, they may be present in various combinations. So let's see. A cobblestone pattern in which the clods are tightly fitted together. They are of different shapes and sizes, but they seem like fitted together like a cobblestone. So that's the cobblestone pattern of the melanocytic nevus. And also the melanocytic nevi are pretty much symmetrical. Some of them are really not, but this one is symmetrical. Okay. Looking at the second lesion in the morphology is a globular pattern. A globular pattern is a nevus in which the clods are not tightly fitted together. They are of different shapes, but they are scattered throughout the lesion. They're not fitted together. So that's a globular pattern of the melanocytic nevus. And the third one, if you see, is a reticular pattern in which there is pigment network scattered throughout the lesion. The color stays brown, in the range of brown, light brown or a darker brown, but it's pretty much symmetrical. It's not asymmetrical. Homogeneous blue pattern is seen in the blue nevus. And starburst pattern is seen in the nevus of Reed. You see these radial streaks throughout the periphery of the lesion, and this is a benign melanocytic nevus. There is a propensity or a tendency to get malignant. And the last one on the right bottom is non-specific pattern. So there is really no specific pattern that you can confidently say it is. So it's a non-specific pattern. So this was the classification of melanocytic nevi based on their morphology. There are 2 more classifications to go. The second one is based on the pigment distribution. Very easy. Uniformly pigmented nevus, or centrally hyperpigmented, or centrally hypopigmented, or eccentrically hyperpigmented, or eccentrically hypopigmented, as you can see, and then multifocal hyper and hypopigmented. So you need to see the morphology of the structures in the nevus and also the distribution of the colors or the pigment. Well, the third type of classification of nevi is depending on the color that you're seeing. Could be light brown, could be red, blue, black, dark brown, white, or gray. So, अब आप इन तीनों चीजों को combine करेंगे, and whenever you are questions or asked to see a melanocytic nevus, or you come across a melanocytic nevus in practice, and I would ask you, or rather I would urge you to specifically go and see for the melanocytic nevi and practice about labeling them. How are you going to practice? You're going to consider the morphology, pigment distribution, and the color. See these 3 things in all the melanocytic nevi, and then right at the bottom of the nevus what exactly it is. Is it a dark brown, uniformly pigmented reticular nevus, or it is eccentrically hypopigmented pinkish globular nevus, things like that. Then you go on and on. So you basically consider three things in melanocytic nevi. These are the morphology, pigment distribution, and the color. Okay, so now this is a lesion, and if I ask you, what is the pattern of this lesion? So what's the pattern? The pattern is that of peripheral globules or clots. You may call them clots. Well, the clots are peripheral, and then there is homogeneous pigmentation in the center. So that's the pattern of clots and homogeneous pigmentation. What's the color? Color is only one. It's brown. Is it symmetrical? Yes, it is symmetrical. So would you like to send the lesion for biopsy? No. Hopefully, you understand my point. Okay, so what's the pattern? It's a reticular pattern. What's the color? It's dark brown. Is it symmetrical? Yes, it is. By the way, this is an ink spot lentigo. And whenever next time you come across such lesion, you instantly know this is not melanoma. This is ink spot lentigo. So pattern, color, symmetry. Okay, what's the pattern? What's the color? And what's the symmetry? Pattern, which is there in more than 20% of the lesion area, is homogeneous structureless pattern. The clue is that on one side of the lesion, there is a dark colored network and few peripheral dots and streaks. There is also some grayish area surmounted by grayish clots. Also, the grayish clots are visible elsewhere as well. So, by any means, the lesion is asymmetrical. Obviously, if you draw two lines, one vertical, one horizontal, the lesion stays asymmetrical. The colors are many. Pattern मैंने discuss कर लिया. So, आप क्या करोगे इस lesion को? Probably, you are going for biopsy in this lesion. Yes. So, अब आपको थोड़ी सी हम drill करा रहे हैं. How you read the lesions, how you interpret the lesions, how you come up with the basic terminology of a dermoscopically seen lesion. So pattern, color, symmetry. Okay, what's the pattern? What's the pattern? What's the color? What's the symmetry? The pattern is like homogeneous pigmentation. Okay. There's no network, there are no lines or dots or clots, but somewhere it's structureless and somewhere there are structures, but they are not making up any specific type of structure, but they are homogeneous pigmentation. However, there are some dots. अच्छा जी, उसके बाद हम colors पे जाते हैं. Color is brown and blue and red and obviously pale or whitish over here, scar-like hypopigmentation. Is it symmetrical? No, it really is not symmetrical. So the lesion is, in my opinion, the lesion needs to be biopsied. There are so many colors, there are so many patterns. Okay, fine. So after having a little bit of drill of many lesions, considering their patterns, their colors, and their symmetry, now let's go and focus to one point checklist or the elephant approach. Now, the elephant approach is the one in which you come across some lesion. I tell you that this is melanoma or a BCC or an SCC, and then you are supposed to memorize the lesion. You are supposed to fix it in your brain, and then whenever a similar lesion is seen next time, you say that, okay, fine, this I saw such kind of lesion. It was a BCC, it was a melanoma, it was an SCC. So you instantly come up without analyzing the arrangement of the structures, without just going analytical, you instantly come up with the name of the lesion. So that's called the elephant approach. And by the way, this figure is depicting all that famous story of seven blind men and the elephant. So whosoever is, touching the trunk of the elephant may say that I'm touching the wall. And who is touching the tail of the elephant may say it's a rope. And if someone is, touching the ear, may call it a fan. and if someone is touching the tooth of the elephant, may say it's a spear. So the one structure is different, but the overall appearance of all these structures combined gives you the appearance of an elephant. So this is the elephant. The first elephant I am going to show you is that of a melanoma. अगर आपको इस तरह की कोई चीज नजर आती है जिसमें there are multiple colors, for example light brown, dark brown, blackish color, and then grayish, of course. Can you see this grayish color? This is so very important in this lesion. And then you see the structures. There are dots and clots, and then there are streaks making up the network at some places. The network goes thicker at somewhere, and then there are grayish areas. At places they are grayish dots, and at other places it is the grayish pigmentation that stays homogeneous. So this is a lesion. अगर इसमें इसको overall आपको बताऊं तो it's an elephant. So whenever you see such lesion in your practice, you may instantly come up with a diagnosis of melanoma, and you would obviously like to take a biopsy. So this lesion is an elephant for melanocytic nevus. It's pretty much symmetrical. थोड़ा मैं analytically आपको इसलिए इसकी description दे रही हूँ so that you may feel confident about it that the lesion is obviously an elephant. So take it as an elephant. It's a benign lesion. The previous one was malignant. It was a melanoma. And this elephant is benign. Elephants जब आप life में देखते हो तो you're not supposed to give details of the lesions. Elephants means that you're diagnosing a lesion in the duration of a blink. तो अगर blink के time पे आप एक चीज को diagnose कर रहे हैं तो obviously आपसे details की expectation नहीं है. आपसे सिर्फ इतनी सी expectation है कि आप उसको benign कहते हैं या pre-malignant या malignant कहते हैं और आप उसकी biopsy करना चाहते हैं या नहीं करना चाहते हैं. हर लीजन को डिटेल से एनालिटिकली देखने की जरूरत नहीं होती. With the passage of time, you learn that which lesions need really your time and which lesions do not really need your time. और उसके ऊपर आपने instantly बस बता देना होता है कि fine इसकी biopsy कर लो. अच्छा ठीक है इसकी biopsy की जरूरत नहीं है. Call him after 6 months. See, so that's how you get more and more confident about it. The purpose of showing you these elephants is a little bit, saving the time, making you able to be confident about some lesions that you may not want to spend more time on. So that's another elephant. One more elephant of benign melanocytic nevus, reticular one. Another nevus, symmetrical lesion. थोड़ी बहुत anatomical variation को we do, tolerate. So not a lot, but थोड़ी सी anatomical variation is there in most of the lesions. This is an elephant for malignant lesion, melanoma. Okay. Another elephant for nevus. अब इसमें आप देखते हो कि यहाँ पे network है on the left hand side, right hand side पे थोड़ी सी homogeneous pigmentation और dots and clots हैं, but this stays in the normality. It stays in the range of normality. So that's an elephant. That's an elephant for malignant lesion. Obviously, this is not tolerable. The lesion is showing typically atypical network over here. It's very much atypical. While on the over here, if you can see, यहाँ पे मुझे तो बड़ा अच्छा नजर आ रहा है. आप अगर pause करके थोड़ा देखें तो the network is there, but it's slightly pigmented, a bit darkly pigmented over here and here. But यहाँ पे left upper zone में जैसे 10-11 o'clock पे ये बहुत ज़्यादा dark हो जाता है, and then there is a blotch over here. So this elephant is for melanoma. Another melanoma or malignant lesion, elephant. And then a benign lesion, obviously, benign. Benign, what is it? This elephant should instantly tell you that it's an SK, it's a seborrheic keratosis. Very much well-defined lesion. Look at the periphery. It's pretty much well-defined lesion with milia-like cysts and comedo-like openings, okay? अगर ये माइलिया लाइक सिस्ट और कॉमिडो लाइक ओपनिंग्स हैं एंड द लीजन इज वेरी मच वेल डिफाइंड, इवन दिस मच ऑफ ग्रेइश एरिया इज टॉलरेबल. Obviously, seborrheic keratosis में there is lots and lots of proliferation of the keratinocyte is going on, और उस वजह से जो deeper down होंगे melanocytes वो आपको थोड़ा सा grayish color देंगे. They are situated deeply in the dermis, and as we discussed in the initial part of the presentation, the melanin which has gone deeper into the dermis gives you grayish or a bluish color. So this stays in the normality, and if you come across such lesions, you just don't have to waste your time or go analytical about it. Just say that this is an SK. Another SK. In this SK, you see more and more of comedo-like openings and milia-like cysts बहुत थोड़े हैं. ये हैं कुछ और एक ये है वाइट वाला, एक ये है. सो कोमिडो लाइक ओपनिंग्स आर वेरी मच देयर एंड माइलिया लाइक सिट्स जो है थोड़े कम है. The dermoscopic picture of seborrheic keratosis depends upon the clinical stage it is in. Okay. Another seborrheic keratosis with so many comedo-like openings and brain-like sulci and gyri, or you may call them fat fingers as well. So another elephant for, what is it? By the way, this is the normal network all of us are having in our skins. This is not normal or nevus or something. This is a dermoscopic image of dermatofibroma. The central part is homogeneous whitish or light colored, and then the periphery is a bit brownish or pinkish. In our skin, it's mostly brown, while in the whitish skin, it's pinkish. So this is an elephant for dermatofibroma. So if such lesion comes, you encounter such lesions, you instantly say this is dermatofibroma. Another elephant. This is an elephant for BCC. Why? जब हम कोई लेक्चर करेंगे नेक्स्ट मे बी थर्ड और फोर्थ चैप्टर हम करेंगे फॉर द डर्मोस्कोपिक डायग्नोसिस ऑफ स्किन कैंसर्स, पर्टिकुलरली एससीसी, बीसीसी एंड मेलानोमा, तो उसमें आई विल टेल यू एनालिटिकली कि why is this slide called BCC. लेकिन अभी के लिए मैं आपको ये बता दूं कि there are so many branched vessels in view and then you have bluish clots and dots. तो ये जो है ना ये BCC की रेंज में जाता है. So this is an elephant for BCC. Another elephant for BCC with central a bit of ulceration or hemorrhage you may say, and then blue clots and dots and obviously the vessels around. So this is again BCC. Another pigmented BCC. So in this BCC, you see pigmented lines in the form of streaks. They, some of them have the same origin. See these three paw-shaped or three lines coming from the same origin. And then over here, floral structures, you may call them cartwheel appearance or maple leaf appearance. So this is typical for pigmented BCC. If you come across such lesion in life, you instantly say, okay, fine, this is BCC. Elephant for melanoma. So many structures, different arrangements, and obviously chaotic, non-symmetrical, range of colors, melanoma. Okay, ये तो हमने पहले ही देख ली. We started the presentation with this picture. So this is obviously melanoma. What is this? Elephant for BCC, elephant for BCC, elephant for SCC. Yes, this is an SCC. Well, you know, these are the white circles, most diagnostic, most specific for well-differentiated SCC. So this is a typical dermoscopic picture of SCC. Another SCC or keratoacanthoma, in which the central part is filled up with keratin and there is hemorrhage and blood. Mostly you see hemorrhage and blood in well-differentiated SCC. So also you see the white circles in the periphery. So these are the white circles in the periphery. And then obviously so many blood vessels, looped vessels, hooked vessels, dotted vessels, glomerular vessels. So the polymorphic vascular pattern, you may say. The polymorphic vessels, also there are some branched, and then there is ulceration, keratin, hemorrhage, bleeding, and white circles. All of them make up SCC. Another elephant for SCC. Okay. So now you have studied two important patterns of diagnosing the dermoscopic images. One was pattern analysis, where you went stepwise, looking at the structures and their arrangements and their colors. And the second method was a one-point checklist or elephant approach, in which you were shown so many elephants. Okay. So there was an interesting study that was conducted on the medical students, and it was seen that both these methods were taught to them, the analytical method of interpretation of dermoscopic image and obviously the elephant approach. So as you can see on the left hand side, the students were shown images pertaining to the elephant approach, and on the right hand side, these are the students who performed on this analytical approach. जब analytical वाली images उनको दिखाए, उन्हें कहा कि you go step wise, पहले उन्हें पढ़ाया गया, ऑब्वियसली पढ़ाया गया, 1 आवर की क्लास ली और उसके बाद इमेजेस दिखाए और उन्होंने कहा एनालिटिकल मेथड से आप इसको देखो कि ये क्या है. सो उसमें द मेल्स परफॉर्म्ड बेटर देन द फीमेल्स. लेकिन जब उनको ह्यूरिस्टिक मेथड या एलिफेंट अप्रोच से उन्हें काफी लीजन्स दिखाए गए एंड दे वर सपोज्ड टू डायग्नोज द लीजन इन अ ब्लिंक टाइम, उसमें खवातीन ने बहुत अच्छा परफॉर्म किया। So, इसका मतलब है जो पैटर्न्स, डिजाइन्स, कलर्स जो हमने दिमाग में बिठाने होते हैं, तो वी कैन डू देम बेटर देन मेल्स। और मेल्स जो हैं, दे गो मोर एनालिटिकल. This was an interesting study, so I thought maybe I would share it. Acha ji, so the next is chaos and clues. So I would like to pause over here क्योंकि ये बड़ा ही important method है और हमने इसको बहुत अच्छे तरीके से पढ़ना है. So I would like to start my next presentation from chaos and clues. और ये वाली जो presentation है, let's have a break over here. We studied the analytical approach, the revised pattern analysis, and then the elephant method of dermoscopic diagnosis. In the third chapter, obviously, we'll start up with this chaos and clues method. Thank you so very much for listening and tolerating me throughout this lecture, and I hope कि आप इसको अच्छा सा learn करेंगे. And I'm going to pause over here. Allah Hafiz.